The common misconception about this disease is that it's a smoker's disease.
Smokes can enter into the lung in many forms. Especially this is relevant in our country like India, where the environment pollution level is high.
Small chest x-ray also, people have so much of hesitation.
Chest X is a passive test.
That's right.
He don't have to do anything.
Anything, right.
And a pulmonary function test, he have to do everything.
कभी कभी कोई सोच लेता है, मतलब उन्हें अस्थमा को भी सीओपीडी बोल देते हैं या सीओपीडी को भी अस्थमा समझ लेते हैं.
Make it separate because the treatment goal or treatment medicines are little bit different. The nature of triggers are different.
What could be the possible triggers for this kind of exacerbation?
What happens in during this temperature change? For if you think about our country, many environmental viruses and bacteria get activated.
So welcome Dr. Surajit Chatterjee, and sir, we all know that you are like a renowned pulmonologist, and it's great and honor to sit with you today.
Thank you for the nice introduction. Actually, I'm basically based on Kolkata, West Bengal.
Okay.
Doing my teaching since last 15 years, and now I'm an associate professor of IPG MER Kolkata, and I'm also have my chest clinics on the city. So I'm used to see patients for past 15 years since my post-graduation days.
That's great. So just to brief you, sir, this is our show, which is Beyond the Pill, where we say that the health meets conversation. And it's a campaign, One Life. It's One Life by Mankind Specialities, where we want to, make our population or our viewers aware of the authentic information coming from the doctors itself, like from a very important doctors, KOLs like you, because there's a lot of misleading information on social media. So that's how we came up with this show, wherein we could thought that let's just do something as a patient awareness program.
No, basically that's a great idea. Nowadays we cannot avoid social media. I mean, people to know what is going on throughout the world. And for medical field also, social media, we are using social media for awareness generation and everything. And for chronic diseases, which have misconception, myths, we have to break it down.
That's true.
That should be the main purpose of this social.
That is how, like, the main purpose is like we want your perspective. So, to start with, our today's topic is COPD, which is chronic obstructive pulmonary disorder. So the common misconception about this disease is that it's a smoker's disease. Anyone who's a chronic smoker will get COPD, but then we all know that it's not true. Yeah, or else we think that the breathlessness that we see in COPD, it's just a old age breathlessness. Second, these are the misconceptions about COPD as a whole. So what's your perspective on this?
No, you are right. If you think about in broader sense, it is basically a smoker's disease, but not only it occurs due to active smoking of cigarette or bidis or weeds, whatever. Smokes can enter into the lung in many forms.
That is true.
Okay.
Yes.
Maybe patient may be a passive smoker, a patient having exposure to household smoke, that biomass fuel exposure. Patient may inhale smoke from traffic exhaust.
Yes.
So what you are trying to say that it's not a smoker disease, this is very true. It not only occurs due to active smoking, but smoke can affect in many other ways. Especially this is relevant in our country like India, where the environment pollution level is high, traffic exhaust is high, there is no control on environmental situations. And also in there is a unique feature in the village areas that the use of chulhas and all.
Yes.
A high exposure of biomass fuel. So that's why in India the female COPDs are the number of female COPDs are so much
higher than female
than the rest of the world.
Okay. So could it be like only chulhas, or even in the urban areas due to the fumes while cooking? Does that also lead to some such? There are people who have their occupation as cooking. So what about
cooking in chulhas? Have a significant role, no doubt about it. But what is happening? Fortunately, for the past few years, maybe past 10 years or so, due to the government initiatives, I must say, chulhas are being replaced by gas.
Gas, okay.
So that is a positive thing from our perspective also. On the same side, pollution in the environment has increased. I don't know what is the situation over here, but many of our ladies from metro cities, they are active smokers.
Yes, big time.
So active smoking is increasing.
That is true.
Rest of the world, it is decreasing. For India, if you see the statistics, the active smoking in females, it is increasing.
Yes.
And that is creating their health problems.
That's
because
true.
females are more badly affected due to smoking than the males.
Okay, why is that?
No, because their lung lung is not adapted to take smoking. Lung is lesser in size. Sometimes in pregnancy, if they smoke, that is much more helpful. I mean, harmful for mother and baby also. There are so many of miscarriages, so many of premature low birth weight deliveries. There are so many pregnancy complications, and you know that smoking can cause increased thromboembolic manifestations also. That can also increase in pregnancy. So in pregnancy, smoking is a big no-no. So not only chulhas, the increased incidence of female smoking, and also our customs. You will be surprised. One agarbatti, studies have shown, we have studies, very Indian studies, that one agarbatti, that small agarbatti, is equivalent to more than 500 cigarettes. These habits, and one panwala at a busy square of a city, even he do not smoke, he can inhale
lot of pollution.
Yes. Traffic exhaust much at higher percentage than active smokers. So these are the unique things of our COPD patients.
But then when we talk about awareness part of it, you think the awareness that we are trying to create for our audience, equally, such kind of awareness is lacking in the population who are literate enough, and even amongst the HCPs too. Because even I have seen many HCPs being like a chain smokers.
Exactly so. इसको बोलते हैं ज्ञान पापी. So not only general population, also we doctors, sometimes we know many things, but we cannot do by ourselves. So that is true. And the message percolate, or we should give to our patients or to our population, whenever we cannot follow that thing, we cannot give the message, we cannot give the correct message to other people. So it is very unfortunate thing, what should I say, that many HCPs are
yes, that's
chronic smokers.
So
awareness part is lacking, very much lacking. That's why COPD, just like diabetes, India is going to become the
next
COPD capital
oh my God.
of world.
So why do you think is that? I mean, is it because of the real increase in incidences, or is it because of the increase in diagnostics, increase in
Both.
availability? Okay.
Both. Real increase in incidences are there also, because we are having 1/5 of world's population.
That's true.
COPD in India is now the second most leading cause of death.
And unfortunately, COPDs or any respiratory conditions are being taken so lightly.
Exactly so. So I used to tell my patients, whenever a patient, I'm just giving an example, whenever a patient come with a lung ailment and he's saying, no doctor, I don't have any breathlessness, I'm just coughing. And whenever I used to do a pulmonary function test, it is already less than 50% lung function has achieved.
Okay.
So patient are asking, how is it so? I don't have any breathlessness, because lung has a great capacitance.
That's true.
In cardiac part,
Yes.
if we have a small chest pain, we used to rush to the doctor. For lungs, until and unless it's 70-80% damage,
That's true.
usually in early instances, it is usually regarded as smoker's cough, or cough is often taken lightly. So that is very dead. I mean, that is the main problem of diagnosing, late diagnosis of lung diseases. That is the main
just like
problem.
going for a small chest X-ray, also people have so much of hesitation or take it so lightly that okay, it's just coughing, it will go away. It could be due to some reason. So,
And people have because for obstructive airway disease, particularly in particular for COPD, asthma, bronchiectasis, it's far more important to do a pulmonary function test than a chest X-ray.
correct.
But people are fond of doing chest
Chest
X-ray
X-rays.
than a pulmonary
Yeah,
function
that's
test.
how it's
Because
rolling out.
chest X-ray is a passive test.
That's right.
He don't have to do anything.
Right.
And a pulmonary function test, he have to do everything. His effort will tell his lung function. So
Correct.
that is the problem.
But I'll
Patients
tell
are
you, sir,
reluctant to.
most of them doesn't even know that there is something called as a pulmonary function test to check your lung capacity. About this, they don't even have an idea that there's a specialized branch such as pulmonologist, which is only specifically for your lungs. So I really want you to shed some light on these kind of screenings as well, where people should understand that what have to be done for your organs. I mean, for everything, you cannot just go to one particular doctor.
No. See, for your first comment, after COVID, the conception has changed.
Okay.
People are much aware nowadays that we have to do a checkup under supervision of a pulmonologist or chest specialist or lung doctor if our lung symptoms appears. So nowadays people actively search for pulmonologists. Beforehand, before what happened, that every chest problem they first go to the cardiologist, then come under the cardiologist, then even simple chest pain, cardiologist used to do angio. They said no, nothing in your heart. Then he used to come down to a consultant physician. Then after maybe accidentally they used to come to pulmonologist. Now the scenario has changed. That is a better thing, because our pulmonology team has also increased throughout the nation. That's right. And second thing, for awareness generation or that camps and all, the big companies have a, I mean, social role of doing this. So because in a mass, one single doctor cannot do these type of things in a mass. So everybody, doctors, the companies, the media, the government, everybody should come forward. That's true. So we, in our city, I personally do many camps with the traffic surgeons or traffic police in collaboration with the police personnel, because they are every time they are exposed with this type of things. We have done these type of things to the school children also, to diagnose early diagnosis of asthma or like thing. But for COPD, mainly for adult patients, we have done it to the traffic surgeons or traffic police. So what is your some basic advice or some recommendations for patient support programs, especially that has been run by companies? How can they help increase the awareness about the same? Oh, there are so many things. Usually nowadays, these camps, awareness generation camps, or doing a PFT in a camp, or a 6-minute work test, or a pheno. These things are happening. Apart from that, we can do a role play like thing. We can observe many days, like World COPD Day. You know that in November there is a World COPD Day, and this World COPD month is going. So we can do other days also: cancer, lung cancer day, no tobacco day, asthma day, whatever it is. By all these means. And every time you should be, by research, by news, you should be in touch with the in the front page. Correct. Updated. That updated and in front should be remain in front page, so that the thing will stuck into the mind of a common people. That is the most important thing. Whenever the things will not stuck into the heart or mind of the common people, they will not act. They'll not. That's true. So, sir, whenever we talk about such conditions, we always combine
COPD अस्थमा, मतलब हर बार ये दोनों टर्म को साथ में यूज किया जाता है. सो व्हाट इज द बेसिक डिफरेंस? लाइक कभी कभी कोई सोच लेता है, मतलब उन्हें अस्थमा को भी COPD बोल देते हैं या COPD को भी अस्थमा समझ लेते हैं. व्हाई इज इट दैट? आई मीन द सिम्टम्स आर ओवरलैपिंग. इज इट दैट वे?
Here lies the, importance of ours, like pulmonologists or chest physicians, whatever. So our primary duty is to make it separate, because the treatment goal or treatment medicines are a little bit different, but there are so much of overlap in between these. See, COPD and asthma both are airway diseases, obstructive airway diseases. But the nature of inflammation is different, the nature of triggers are different. For asthma, the trigger, it's a early age disease, basically. Late onset asthma is there, but primarily it's an early age disease. Initially it happens with different triggers like dust mites, environmental pollutants, household pollutants, maybe fungi, pollens, insects, foods, emotional stress. These usually triggers. These are regarded as asthma triggers.
Okay.
Right. For COPD, it's primarily a man-made phenomenon.
Okay. खुद के पैर पे
Asthma has a strong genetic predilection, but COPD, as we have discussed, that is basically a smoker's disease, and also from environmental pollutants or pollution. Uh, Basically, what happens is a neutrophilic inflammation.
Okay.
So for asthma, it's primarily an eosinophilic inflammation that the response to inhalational corticosteroids and inhalational medicines are very good.
Okay.
And if detected on time, asthma is mostly a reversible disease.
Okay.
And nowadays, in guidelines, there is a new term, that is remission of asthma.
Yes.
So remission part has been incorporated in asthma because remission can be possible.
Okay.
But for COPD, it is not so much promising. Nowadays, so many drugs are available. They are very novel drugs. They act very good. We can keep the disease in control. The main goal of COPD are two. One is prevention of exacerbation, and number two, symptom control.
Okay,
One age elderly people do his own job, own work freely with medication without no or minimal exacerbation. This is the main thing.
So what do you mean by exacerbations?
Yeah, I'm coming to that. So one exacerbation means deviation from the normal. I mean, deviation from the stability. A stable disease means the people is a diagnosed patient of COPD or diagnosed patient of asthma. He has consulted physician. He has given appropriate medicines. And with these appropriate medicines, the patient condition remains stable. He is doing well.
Okay.
This is called stable COPD or stable asthma.
Okay.
Whenever there is deviation, I mean, there is increased cough and sputum production.
Okay.
There is increased shortness of breath. Maybe fever. These are the, maybe chest pain. These are the signs of exacerbation.
Okay.
So in a patient with stable COPD who is receiving treatment properly, whenever faces this kind of problem, she should need immediate medical attention.
Okay, understood.
These are the red flag signs.
Okay.
I must.
So, what could be the reasons for the disease to flare up like this? I mean, is it that the global warming, as we say, like the sudden temperature rise or decrease? Or, I mean, pollution, we know that pollution happens, but then what could be the possible triggers for this kind of exacerbations?
Yeah, for asthma, we know the triggers.
Yes.
Viral infection is commonest trigger for asthma. For COPD also, what happens during this temperature change? For if you think about our country, we have a temperature difference during the month of October, November.
Correct.
So when from summer to winter is coming, and another from late February, March.
Yes.
When from winter the summer is coming. So what happens? The many environmental viruses and bacteria get activated due to this temperature change. Those are get activated within the respiratory system also, because a COPD patient has a less lung immunity than a healthy people.
Understand. Okay.
So when the immunity is less, and whenever there is change in temperature and all, these things get activated, and that may cause to a viral infection can cause exacerbation. Okay. Environmental pollutant exposure can cause exacerbation. Any deviation from normal lifestyle can cause, and even whenever we are talking about severe COPD or very severe disease, you cannot even understand that what causes the exacerbation, because they don't have the lung reserve. Correct, correct. So for all the COPD patients, they are put on inhalers. If I am asking you that for all skin condition, do you recommend inhalers? The question is just like that. For obstructive airway disease, for airway diseases, because basically it's a COPD is basically a systemic disease. Mind it. This is also a very chronic. No, it's a very basic conception that COPD is not limited to lungs or not limited to airways at all. COPD, the basic pathophysiology of COPD, it can damage airway, it can damage the lung alveolar architecture, that emphysema part, and it can cause systemic inflammation. Okay. That's basically a imbalance between oxidant and antioxidant, right? So it can cause systemic inflammatory reaction that can cause cachexia, that can cause anemia, that can cause increase in interleukins and all. Many things. So COPD is not limited to lung basically, but what we are talking about, what was your question? That inhalers are essential or not? So basically our target is airway and lung. To reach that airway and lung, the easiest thing is to give inhalers, right? Okay. So if I give a COPD medicine in a tablet form, see, we have to swallow it. It will go to the stomach. It will then enter into the liver. Liver will digest something. Then the raw materials with the active ingredients will go to the mix with the blood, and blood will circulate throughout the body. Right. And a small proportion of that medicine will go to the lung. That is the target organ. Okay. On the contrary, if we give inhalers, it will directly go to the lungs or the airways, right, which are the main target. See, we cannot avoid this part, our oral part, because for skin we can apply it directly, but we cannot open our chest and apply inhalers directly. So we have to take it by mouth, and with our active participation of COPD patients, it has to be taken within the lung. So inhalers are the basic solution, and in compared to tablet, inhalers, the medicines, those are used in inhalers, those are in micrograms. Correct. So the dose is much lesser than swallowing it. The side effects as well is much lesser than systemic side effects are basically nil. Okay, correct. That is important to understand. So any patient who has COPD and is taking inhalers needs to really accept that this has to be taken for a longer time or for lifetime, and adherence there comes like a big problem. COPD, that disease, when patient used to come to us, it's generally a little bit late, that 60-70% lung damage are there. So this doesn't happen in a single day. It requires many years to develop COPD. That's right. Many years of smoking or many years of environmental exposure. So if this disease doesn't develop in a single day, you cannot take inhaler for 5 days or 10 days. You have, and it's a progressive disease. Gradually, generally without medication, the disease will progress. Correct. Whether you quit smoking or not. That's right. But quit smoking, yes, definitely have a positive impact. But the COPD, by definition, it's a progressive disease. So to reduce the progression or to keep the patient symptom free, you have to take inhaler. And usually for COPD, it is lifelong. It's lifelong. Sometimes patients, after getting better, or after getting some symptom control, usually drop it out. Yes, but this should never be done. Never be done. Exactly. That's the message from here is that do not stop the inhalers or your therapy without, at least for COPD. Yes, because in asthma, with many medications, biologics, remission is possible. We can drop the medicine, but not for COPD. Okay. Still now not. But why do you think that COPD cannot get detected in the early stage itself? As we are telling that one lung has a great capacitance.
Yes. Okay.
It has positive impact as well as negative impact. Negative impact in that sense that usually patients with lung disease are detected late. That worldwide body, that global initiative for chronic obstructive lung disease, nowadays there are many changes have been made to early detection of COPD, like early COPD, pre-COPD.
Okay.
These terms have been applied. So this is for doctors, but patient has to come.
Yes.
Patient should not ignore their respiratory symptom as
Correct.
just like cough or just like मुझे जुकाम आ गया, ठंडा लग गया, not like that. So if you are a smoker, or even if you have a family history of chronic lung disease, if you are a city dweller, if you are more than 40, definitely you should do a checkup with a proper checkup, proper doing a pulmonary function test, doing a chest X radiograph under supervision of pulmonologist.
So, just very quickly, what are the 5 symptoms that should not be ignored by the
Probably
patients?
we are discussing in between that initially, if a patient, there are 6 cardinal symptoms of respiratory system. Most common is cough, and if it is chronic means it's more than 3 months in 2 consecutive years.
Okay. Okay, understood.
If more than 3 months in 2 consecutive years, it could be a early symptoms of COPD or chronic bronchitis. It should not be ignored.
Okay.
As well as chronic sputum production.
Okay.
Chronic cough and chronic sputum production. It should not be ignored. If there is any shortness of breath,
Okay.
gradually increasing over time.
Okay.
If an elderly people is getting slower than his contemporaries or her contemporaries while walking,
Correct.
it should not be ignored.
Okay.
There is any blood from the mouth, that is called hemoptysis, it should not be ignored.
Okay, understand.
Like that. And after diagnosis, I mean, a diagnosed patient of COPD or a diagnosed patient of chronic lung disease should not ignore those red flag signs, like increase in sputum production, increase in cough, chest pain, increase in breathlessness, fever. These symptoms can be our early features of exacerbation.
So, as we have so many advancements and as we have so many new guidelines coming up for diseases itself, similarly, do we have new advancements done in therapies? Like, are there smart inhalers or better medications for COPD now?
Definitely so. Compared to last, 5 years back, we have so much of options. So much of options. It targeting the patient perspectives mainly. Because we have previously for moderate to severe or very severe COPD patients, we have to take multiple inhalers. Nowadays, combinations are available in single inhaler form.
Okay.
So that is more convenient for COPD patients. The failure to take inhalers or the forgetfulness is much lesser. So if you have to take a inhaler twice a day, it is much easier than
Correct.
taking a inhaler,
Yes.
2-3 inhalers
That's right.
6 times a day.
That's right.
So that is possible nowadays. And the most recent advance is once daily inhaler form is available in capsule form, but that is also available, and that is very much effective. There's very strong data on that combination. Next thing is, apart from home nebulization has come, promisingly, though the more drugs are available in nebulizer form, that are chronic COPD patients or elderly patients who are unable to take inhalers, they can use nebulizers if they have the family support.
Nebulizer has been like very underrated as a therapy, but then it has a very good impact on the recovery.
There are so many studies are coming on chronic use of home nebulization.
Correct.
Apart from use in ICU or hospital setup, in home setup also nowadays nebulizer are mostly affordable.
Yes.
So patients are also patients who have suffered or who have experienced 1 episode or 2 episode of hospitalization.
Yes.
They are very receptive. Correct. Because they know the pain
Yes.
pain of that hospitalization,
Correct.
having being shifted to ICU, putting in BiPAP, the agony of the family, the cost,
Right.
they used to know. So those people who have experienced one or two times of hospitalization, they are most receptive of all these therapies. And apart from these, pharmaceutical therapies, there are so many things for COPD, like preventive therapies, like vaccinations.
Yes.
That has also gained importance or public awareness after the COVID. Next, the pulmonary
That's important.
rehabilitation,
Yes.
that
Yes.
physio and pulmonary rehab,
Yes.
the importance of good nutrition has been
Nutrition. Yes.
emphasized.
Yes.
So all these things all together can make a COPD patient, can give a COPD patient a better future.
So now that you mentioned such three combinations, I have a good news. Like, we have a patient support program called as SWAS 365, wherein for all such chronic respiratory cases, or any chronic or any non-communicable disease, we have dietitian support available. We have physiotherapy support available. We have some medicine support available, device demonstration support available for all our patients.
No, that should be. Otherwise, pharmaceuticals should come forward, because in any form of disease which is underrated, underdiagnosed, doctor by himself or herself cannot do it by alone.
That's
Because
right.
it should be in collaboration with pharmaceuticals, their corporate social responsibilities, and it should be in in communication or in good touch with the government also.
That's right. So, just before concluding, one very strong and important message that you would like to give to our viewers, to understand, to make them understand that even the lung health really matters.
Definitely. As a pulmonologist, I must say, don't ignore your lung health. We are there to give strength to your lungs. So, whenever you are facing any respiratory problem which seems chronic, like cough, like chronic sputum production, like gradually increasing breathlessness, like chest pain, if it is chronic or if it is gradually increasing, then please go to your doctors, go a proper checkup, do a proper checkup done with lung function, with chest radiographs, get yourself diagnosed and diagnose early. So that whenever the early you diagnose, the more available options are there.
That's right.
And the less you will be progressing to the chronicity or the severeness, you will be facing to severeness of the disease. So get your lung checkup done as whenever you need, and don't ignore to get it checked up regularly. Especially you are a city dwellers or you are a chronic smoker. So COPD is nowadays a pandemic. This more prevalent in India, and the diagnosis of COPD is still in the tip of the iceberg. So get your lung checkup done. This will be my earnest request to everyone. So, thank you so much for being a part and helping us spread the awareness. And thanks a lot for your time. Thank you. Thank you for your nice time. I hope you liked the program. Yeah, definitely so. Thank you. Thank you. सो आज के एपिसोड से हमें ये पता चला कि इनहेलर्स या एनी काइंड ऑफ मेडिकेशन कितनी इम्पॉर्टेंट है सीओपीडी जैसी कंडीशन को मैनेज करने के लिए। तो अगर आपको हमारा ये एपिसोड पसंद आया हो तो मेक श्योर कि ये हर घर तक पहुँचे, और स्पेशली हर एक एक इंसान को जिसको ये एपिसोड हेल्प करेगा। और अगर आपको हमारा एपिसोड अच्छा लगा हो, सो डोंट फॉरगेट टू सब्सक्राइब टू आवर चैनल एंड फॉलो अस ऑन इंस्टाग्राम. It's one life by Mankind Specialities. Until then, stay informed, stay healthy.